and check. Cathi is one of the principal investigators on the HeLTI project, which is how she and I met. And I was very lucky that she agreed to give us this presentation on early childhood health and development in South Africa. So when the talk finishes, we're going to be taking questions both from the room and from the Zoom. Welcome, Cathi.
Hi, everyone. Thanks very much for coming, and thanks for the opportunity to speak this afternoon. I'm going to give you a bit of a whistle-stop tour through a number of years of work in early childhood health and development, both in terms of research that we've done and then how we've tried to use that research to make a difference. So I thought just give a little bit of a background. Let me get rid of that. So my background is in psychology and the social sciences, and then later public health. Primarily a qualitative researcher, but I've landed up in all sorts of other ways of research methods and worked a lot on developing and evaluating community-based interventions, particularly around physical activity and dietary behavior in children and youth. But we'll explain a bit how we've progressed from that. I work primarily in low-income contexts, where issues around unemployment, poverty, food insecurity, crime, safety are all very much topical issues. And in early childhood, I've worked around healthy behaviours, which we'll talk a bit about, and development as well. So I'd like to explain where it all began. So this is in what we call a township in Johannesburg, South Africa, an area called Alexandra. And I was doing some early childhood development testing, and this was quite a typical preschool. So there was no running water, just basins outside. I'm not entirely sure there were toilets, and that was half of the playground for these little kids. But for that project, I was sitting doing testing. As many of you, if you've done early childhood work, you're sitting on one of those tiny little plastic chairs at a preschool so that you can be on the right eye level. And there was a drinking establishment that had fired up at about 9 o'clock in the morning. This was my first project with young children. I'd worked with primary school children before, and I just had this realization that if we didn't do something to help these children, they too could land up drinking it up at 9 o'clock in the morning. So that was kind of really a turning point in my career in terms of just really understanding the importance of early childhood. And I could spend all afternoon telling you about all the challenges in our country. There are many, and our young children kind of need all the help they can get to be kind of put on a healthy path and a better trajectory in life in terms of both their health and their development. So after starting that research, we landed up doing a whole lot of work in what we call ECD centers, early childhood development centers, in both urban and rural settings, done some work in home environments, and initially focused on healthy behaviors in young children because that was where the biggest research gap was. But then soon realized that we needed to figure out how did this fit into the broader context of early childhood development. Obesity prevention much further down the line is not really that salient to people living in really challenging circumstances wherever you are in the world. And we really needed to find messages and a way of framing our work that really resonated with caregivers, with practitioners, and ultimately with broader level stakeholders that could potentially have policy impacts. And we looked at things around school readiness, which I know is a contested term, but I guess provides a broad, some kind of broad term to describe how we prepare children for school. And it's a very salient outcome, and it resonates really well with our caregivers. Done a lot of work around executive function as a marker of cognitive development, and more recently looked at outcomes around early numeracy and social emotional development. So our first project was actually on gross motor development. I was working very much in the physical activity space. I was in the exercise science and sports medicine research unit, because that's where you can do a postdoc when you have a PhD in public health and you can't find a job anywhere else. But no one else had actually measured gross motor skills across different income groups in South African preschool age children, so around kind of 3 to 5 years. And a lot of the research had come out of North America and was really emphasized that children needed a lot of instruction, and, they don't just develop these skills by just playing, they needs to be quite intentional. But we actually found, when we compared against US norms of the test of gross motor development, that rural low-income children who had no instruction, very little equipment, but quite a lot of space, actually perform better than urban low-income and urban high-income children. So this really challenged us. And initially our project was around, can we use motor skills to promote school readiness and movement and all of these things? And we realized no one was going to give us money to do an intervention to improve motor skills when the motor skills were already actually quite good. And it just helped us to start to think, what might be different about our context in South Africa and what hasn't actually been studied and understood well in comparison to a lot of research coming out of high-income countries. We also looked at physical activity. We put accelerometers on them for usually about a week. And this was really interesting because a lot of work was now coming out about how much physical activity should children be doing. The recommendation for this age group was 180 minutes a day, spread throughout the day. Our children, on average, were doing 457 minutes. So no one was going to give us money to improve physical activity either. But what was really interesting, and this is probably one of our favorite graphs from one of our PhD students, is just what those patterns look like in different settings, and really helped us to understand that, like in most countries, you can't say, well, all South African children do this or all Canadian children do this. And it's really important to understand the context of that activity and what do those patterns during the day look like, and what does that tell us about what life is like for children in these different settings. We also used accelerometry to measure sleep, and we found that this was actually the biggest issue in urban low-income settings, where children often went to bed really late, didn't have bedtime routines, and a lot of these settings is very high population density. So families quite typically, if not in the same room, if not in the same bed, at least in the same room. So saying, you go off to bed in your bedroom and close the door and all of those kind of things is just not really reality. So it's trying to understand, how can we message and think around this behavior when we have quite a lot of environmental constraints. We did find that children who had shorter sleep had a higher BMI for age, even though they also had these very high levels of physical activity. And again, that the evidence showed that this was really much more of an issue in urban low-income settings. So this was one of the studies we did in an area called Soweto, which is a low-income urban setting in Johannesburg. And what this really showed is that, and I don't know if this is similar in early childhood centers in Canada, but kids in preschool have naps during the day. But what we were finding is that they were actually kind of having short night sleep and then making up for it with a really long nap at preschool, which is fine when you're at preschool. But when you're going to transition into what we call our reception year, or your start of primary school, you're not going to get a 2-hour nap during the day. So you can see how this can start children on kind of a trajectory of sleep debt. Very interested in screen time. And obviously the nature of technology kind of really fast outpaces our ability to keep up with research. But some of the initial work we did showed that this was really an issue across different contexts. The rural context we were working in at the time actually had really low screen time, partly because they didn't have a great supply of electricity. So obviously that makes a difference. And in urban high-income settings where kids had much more access to devices, we actually found that the levels were higher there. And what was quite concerning, and this is probably our last study with high-income parents, because they were much more high maintenance to work with and hard to get hold of. But they actually didn't think that, screen time would affect their preschoolers' health. And I think that has changed. That research was quite a number of years ago. But it did show that even if parents have access to information, access to all sorts of resources on the internet around screen time, that maybe some of these messages weren't necessarily getting through, and parents maybe just weren't always feeling like they had the skills to manage this behavior as well. And around that time, I got involved in a study called Sunrise, which is the international surveillance study of 24-hour movement behaviors in the early years. And this was actually a study that came out of the WHO's Ending Childhood Obesity report, and thinking about how can we promote healthy behaviors that can counteract childhood obesity. And it's now over, I think, more than 50 countries. A large proportion of that is low middle income countries. And this study also just was in line with the move towards understanding 24-hour movement behavior. So not seeing these behaviors as kind of discrete behaviors, but really seeing how do they interact and intersect throughout the day, which also provides a more cohesive message for caregivers, for parents, for practitioners, teachers, understanding how do these behaviors fit together. So we were part of the initial phase of this Sunrise study, and we compared again urban and rural settings, and actually again found kids were doing well in terms of physical activity, less well in terms of sleep, and even less well in terms of screen time. And only about a quarter of them were actually meeting all three of the guidelines. And in this particular rural setting where we were working, we actually found that screen time was really high, which indicated to us that there are these trends and these things are changing. So we can't always assume in rural settings that screen time is not an issue. And again, found that kids were generally doing well in terms of gross motor skills. We also did some qualitative work to try and understand parents and caregivers and teachers' perspectives around all of this. And we talk about caregivers a lot because in South Africa, in low-income settings, it's often what's not unlikely, but it's quite common that the children are raised by a grandparent or some other female caregiver, or male, mostly female. But actually, when we did this work, we found that they were generally positive about health behaviors. And again, it confirmed what we were thinking, that child development for them was more salient than their physical health, but there were these big gaps in terms of their knowledge about particularly things like screen time, but they were really keen to learn and they were receptive to these messages. And also confirmed that screen time was becoming much more of a problem, including in rural areas, and that they were open to kind of learning more about this and open to intervention. Some other work that looked a little bit more around nutritional factors as well. It also highlighted how there are these many environmental factors that influence behaviors and influences choices relating to the health and the weight of their children, but that health isn't necessarily this guiding principle about everything that they decide for their preschoolers' health behaviors, and things like practicality and financial constraints and aspirations for sometimes unhealthy things also come into the picture. And obviously concerns related to their socioeconomic status around unemployment, poverty were also things that were guiding many of their decisions. And what came out of this as well, that confirmed kind of the impression we'd had from the research we'd done that far, but is that children did want their children to learn and to develop and to feel happy and loved. And that our interventions should promote nurturing care in a way that ultimately also promotes healthier habits. And it was around this time that the nurturing care framework had come out. And so that was helping to guide some of our thinking around that and help give us some language in terms of how we frame some of these messages. Also around that time, we discovered this thing called executive function. And this was part of a project where we are actually looking at, was executive function as a marker of cognitive development in this age group associated with physical activity and motor skills. There's a lot of talk about how physical activity, motor skills activities could really promote children's cognitive development. Not a lot of research in low middle income countries, although that is changing. So the couple of main things is that a lot of the literature led us to expect that these children would do really badly in terms of executive function, but they actually did better than expected, even in really vulnerable settings. And it wasn't related to physical activity, possibly because they were doing so much of it, but it was associated with gross motor skills. Our best finding unfortunately for our Canadian/Australian collaborator who developed the test that we were using, is that our children actually outperformed the Australians, which if you know anything about sport, we take any opportunity to outperform the Australians. So we did rub it in their faces a little bit. But yeah, this was really surprising that even for some of the outcomes, children in the poorest quintile, which would be rural, low-income South Africa, actually outperform children in the highest quintile in Australia. So we are still trying exactly to figure out why this is the case, but yeah, it really helped us to see that in these settings, despite all these challenges, children have the capacity to learn. They have this underlying cognitive ability. And what is it about that environment that's able to harness that or to really maximize that? And what are the things that could be done to make sure we capitalize on those cognitive skills and actually see how can we translate that into better outcomes further down the line. We did also look at school readiness, specifically a test that looked mostly at pre-academic skills, so a somewhat narrow range of how children are ready for school, so not really looking at the social and emotional aspects of it at that stage. And as was expected, children in rural areas performed less well in terms of their pre-academic skills, but we did see some of the expected relationships between executive function and pre-academic skills, but also it highlighted there were other factors influencing school readiness in these settings, which we're also still trying to figure out. And this led to some more work around early learning. And at this stage, we also realized we were working very much at community level, but we wanted to do this in a more meaningful and more responsible and sustainable way. And in South Africa, we have a very thriving early childhood development sector, mainly because the government doesn't do anything, but there's an amazing network of community-based organizations doing incredible work. And we, through some of our other work, partnered with an organization that had a home visiting program for children who weren't able to attend preschools because they're not government subsidized, so parents need to be able to afford to send them, so many families can't. So about a third of children in the 3 to 5 age group don't attend any kind of early learning program. And we were really interested then in understanding what are some of the risk and protective factors for early learning and cognitive development. Previously, we looked at kind of socioeconomic status from quite a broad community level, and we wanted to see now if we went to a more granular household and community level, were we going to see any differences? We were interested in things like exposure to violence, family dynamics, and the home learning environment. Some other work that we did with the same program, but through some of the ECD centers they worked with, looked at associations between executive function and stress. We're still analyzing that data. And for all of this, we took quite a social ecological perspective, so understanding the different environments that children are placed in. So executive function was kind of our central thing. We looked a lot at early numeracy and actually found that numeracy and the home learning environment weren't associated. Self-regulation and violence were also not associated, but we did see some of the expected associations between executive function and numeracy and early learning using the International Development and Early Learning Assessment. The expected association between early learning and some of the household and community factors. But this work has really also just highlighted to us that some of these relationships, we still need to dig deeper into understanding, are there some of the nuances that the measures that we're using are not really capturing? And so it feels like a ongoing work in progress to try and understand that. But I think overall, the home factors specifically didn't really kind of unlock all the answers that we thought that might have. And it's perhaps because differences between the home environments are not that great within the same community. So again, we're doing some more qualitative work to try and understand that. Some of the qualitative work that we have done is using the social ecological perspective, understanding what are the risk and protective factors, at least from the caregiver's perspective. And in some of our previous work, it had seemed that caregivers didn't really see themselves as playing a critical role in their child's development. And this does come up to some degree still, that, you know, you feed your child, you wash them, you send them off to preschool, that's where they learn. And if they can't go to preschool, then they stay at home, but then they don't necessarily have a sense of agency around what role can they play. But what was actually really encouraging is that when we deliberately spoke to caregivers about this, they did actually see that. They saw they had a role in developing and nurturing, providing for, protecting, and disciplining their children. But obviously the risks around low socioeconomic status, some dysfunctional family relationships, particularly with partners, caregiver mental health, those were some of the risks that they identified within their family and home context. Yeah, and then things like in the community context, safety risks, violence, crime, but also resources in terms of the social support that they experience. So that really helped to highlight for us that perhaps caregivers maybe felt more agency than we'd given them credit for, but again affirmed this need to really tap into that, what we feel somewhat universal desire to connect with their children, that they do love them, that they do care for them. And so can we frame what we're doing around that rather than about what behaviors can you change? And this underlying desire, which we do pick up, that they want their children to be ready for school. They want their children to do well at school. And so how can we frame what we're doing around that? And, you know, empower them as caregivers in that role to help move that along. So kind of weaved into all this evidence gathering, we've been looking at how do we use this information to make a difference? So the first part was around 24-hour movement behavior guidelines. So this linked very much to the Sunrise study. And I was explaining to Magdalena, we've got a really nice community of colleagues around the world who work in this particular area. The Canadians are the front runners. So they've really kind of paved the way for the rest of us and provided a lot of help and support along the way. So we, with the help of an Australian colleague, worked to develop guidelines for these behaviors in children from birth to 5 years. We followed a rigorous process with a very strange acronym, and pulled together a consensus panel of government representatives, ECD experts, NGO representatives, health practitioners, and researchers. We had a really robust stakeholder consultation program. We did qualitative work with parents and caregivers, practitioners, community workers, health professionals, various professionals, and also through one of our consensus panel members were actually able to even consult with different national governments, representatives, as well as NGOs, and really felt quite confident in the process that we'd undergone, and really brought in a range of different perspectives around these type of guidelines. How could they fit with other health messages? How could they be relevant and framed in a kind of acceptable way for people working on the ground with young children? So these are our guidelines. Happy to share any of these electronically with you. This was the kind of the written description that explains the kind of preamble and what the different guidelines are. Our government representatives said no one's going to read this. So you have to make an infographic, which we did. And yeah, broke it down into the different age groups. And many of us who'd been involved in different country guidelines were actually all involved with WHO guidelines on the same behaviors for the same age group. And we were really fortunate enough to actually be able to use the systematic reviews of the evidence and then build on with some local evidence as well. So these align with WHO guidelines, with the Canadian ones, with the Australian ones as well, and really try to simplify it because parents and caregivers don't always know what physical activity means, let alone sedentary behavior. Even health professionals these terms don't always resonate. They don't translate well into other languages. So we talked about moving, sitting, and sleeping. And I'm not going to go through them in detail, and many of you may be familiar with these type of guidelines. The other recommendation was that we either have it in one language or all 11. So we have it in all 11. 11 doesn't fit neatly on a page, so this is just 9. But we have 11 official languages in South Africa, and so we've put all of those together. And we had this amazing launch in December 2018, and if any of you have been involved in any kind of guidelines or clinical guidelines, you know that the launch of the guidelines feels like the end of the process, but is actually the beginning. Because now how do you get these resources that you've put all these blood, sweat, and tears into the hands of the people that can use them? We couldn't go into all the households and preschools around the country. So again, we tapped into this organizational network in the ECD sector to help disseminate these guidelines. So we adopted a bit of a train the trainer model and basically did a number of workshops around the country, invited whoever was keen and willing to come, went through the guidelines, gave them a whole lot of printed resources, because we unfortunately can't rely on online dissemination because many people don't have access to internet, to computers, data is expensive, all of those kind of things. So we then worked with the organizations to upskill them about the guidelines, provide resources so that they could take those messages back. And we did some work on evaluating this. We got as far as planning some trips to follow up, and then COVID started. So unfortunately, I don't think we were able to kind of sustain the process as much as we would have liked. And obviously, in many of these organizations who work in vulnerable communities, as you can imagine, at the start of the pandemic, they pivoted to a whole lot more pressing issues like feeding families and those kind of things, and figuring out how to make sure children didn't lose a whole year of early childhood development stimulation. So yeah, so I wouldn't say it was quite dead in the water, but it we weren't able to sustain it as much as we hoped. So the other way in which we've used the science and the evidence is around intervention development, and the project that Magdalena mentioned, the Healthy Life Trajectories Initiative, HeLTI. It's a 4-country study between Canada, South Africa, India, and China. And in South Africa, our randomized control trial is called Bukali, which means smart in one of our local languages. And this is a set of interventions that starts in preconception and goes through all the way to the age of 5. And so for each phase, there's a different set of intervention materials. And we've used the learnings from all of these things around health behaviors and development to particularly put into the early childhood phase. I also worked with some colleagues who had some grand challenges funding. I think it was the All Children Thriving, Saving Brains. So they had a birth to 24-month trial, and I helped them with some funding we had available to actually develop an additional year. We were again able to incorporate some of these health messages, the guidelines, as well as nutritional messages to continue that intervention for that particular trial. So for Bukali, the early childhood phase is Bukali Mtwana, and Mtwana means child. And so here we look at child development, so all the different domains, motor skills, cognitive, social, emotional, numeracy, language, and literacy. The caregivers that we consulted with as part of the preparation phase, they highlighted that they want to know, how's their child doing in comparison to other children? They don't get a lot of this kind of feedback in our primary healthcare services. So we've even put together some developmental milestone checklists just so you can have a sense of what should your child be doing around these ages and get a sense of where they fit. Obviously, child growth is an important aspect of this. So we've also linked it up to what's called the Road to Health book, which is a resource that they get in their antenatal care, and to track their child's growth, their height and weight throughout the first 1,000 days. Also the child healthy behavior. So that's our way of then incorporating that in, sharing those messages around physical activity, sitting time, screen time, sleep, and diet as well. And in this particular project, maternal mental health has really kind of risen as one of the big priorities, bigger than we probably initially anticipated. And so a big component of the early childhood phase is the maternal well-being as well, and particularly focused on social and emotional awareness, stress, coping, and self-care. And then also activities that they can do at home with their child, again, creating these opportunities for nurturing interactions, helping to develop those loving connections between them. So these are just a few of the ideas. We've got one activity where they make a ball, they can use that to play together. One other activity, they grow a bean. I'm sure many of you did that, as did I at some point in your childhood. We used it in another project, and it was like the favorite activity. And it's a really cool illustration of how children grow differently, and how when you kind of make the roots healthy and provide it with enough water and all of that, that it helps them to grow strong. And then a coloring activity. And then from the healthy behavior point of view, part of the homework for some of the sessions is also to do some behavioral monitoring. So tracking their child's sleep, what their child eats, the child drinks, because even in this very food insecure environment, sugar sweetened beverages are consumed at astronomical levels. So really understanding, how that affects the child's behavior, how it affects their child's health, their child's sleep, and then also keeping track of their child's screen time. We aren't thick into this phase of the trial yet, so we don't have as much feedback about how it's working, but these are just some of the activities that are lined up for that phase of the Bukali trial. And then also some resources. So this is kind of a collection from other projects. So obviously the movement behavior guidelines we give to them. From our early learning project, we have a numeracy resource, and then from the All Children Thriving, we put together shapes, colors, numbers. So we try and provide those for the moms as activities that they can take home and do with their child. So as you can see, we're trying to cover all the bases. And then our current project, so this is more around digital tool development, which is a whole new experience for me after advocating against screen time. I feel a little bit guilty for developing something on a screen, which is not for the child, but this is a collaboration with some colleagues at the University of California, Irvine. It's funded by the Jacobs Foundation, and it's called the Series Network, Connecting the EdTech Research Ecosystem. So we're collaborating with some colleagues who work in the field of human-computer interaction. I'm a pediatric psychologist, and then partnering with many of the community organizations that we've been working with to co-design a digital tool for use at home and at community level. And the aim of this tool is to assess social emotional development and mental health in 3 to 5-year-old children from low income settings, to provide feedback on the results and some resources. And where this really comes from is to help build capacity at community level to address these particular developmental issues, because children with these challenges just fall through the cracks. There just isn't the help that's needed. And while we certainly can't replace professional services, we really saw a need in the work that we've done in communities and with this age group to really see what can be done to at least put some tools into the hands of those working at community level to go some small way to plug some of these gaps. So we engaged in this co-design process with assistance from our computer science colleagues, did a gazillion focus groups to really understand what's important for them. So we can come in with this great idea, we want to assess this, but is this important? We could see that we thought it was important, but we wanted to get their perspectives as well. We wanted to present some initial ideas of what could this tool actually look like. And we proposed to use the Strengths and Difficulties questionnaire as a mental health screener, and then the IDELA social emotional subscale. So that was the early learning assessment that we'd used in some previous work, and that it worked quite well. We then took that feedback, developed an initial prototype of the tool, did more focus groups with other organizations to get some more feedback. What did they think was important? Could this work for them? We then finalized the tool for piloting. And in March this year, we did training with the community-based organizations who were involved. And we just finished the final follow-up visits a couple of weeks ago so it was the pilot was very focused on the feasibility and acceptability, but obviously, does this show any potential for kind of shifting children in the right direction in terms of social emotional development and mental health? So you would have seen the logo. The name of the project is Mazi Mtanako, which means know your child. And first of all, it came very clear that this was a very important topic for organizations. Many of them said, we're already trying to address this, but we need help to do this more. We did ask for name suggestions, and the name actually came from one of the community-based organization staff members who said, we don't know our children. We need to know our children. What they also talked a lot about was how developmental challenges are stigmatized, how there's this lack of accessible services for children. Sometimes there are services, but they're far away. And who pays your taxi fare to get there? You don't have a car. So there's all these kind of really practical barriers to actually accessing the help that they need. And they really liked the questions from the SDQ and the IDELA. So we thought we'll give it a go. And WhatsApp is a very, very, very commonly used digital platform in South Africa. Most people are connected by WhatsApp. And that was what we'd proposed as an idea, as a way to use the tool. So essentially, the tool is a WhatsApp chatbot. I'm not sure how common WhatsApp is in Canada, but so some of you might be familiar with that, but it's all kind of programmed into WhatsApp. Again, the need for multiple languages came up. And also importantly, they gave us so much feedback on how to integrate this into existing work. And I think all of you, in whatever setting you work, you can come up with a wonderful digital tool, but if people can't actually find the time to use it, or it gets in the way, or it's just too cumbersome or too time consuming, whether that's a nurse, a clinician, community health worker, home visitor, it's not going to fly. So we really needed to make sure that we could understand how would this integrate into their workflow. And I also just wanted to highlight, so we have a paper in preparation where we've highlighted the risks and protective factors. You might see a theme throughout some of our work. And again, looked at this through the lens of the nurturing care framework. And I won't go into too much detail, and hopefully the paper won't take too long to eventually publish, but unfortunately the risks far outweigh the protective factors. So this was from the perspective of these community workers, of these home visitors. So they were reporting on what they saw in terms of what's happening in the home, what's happening in the community. And even though we'd seen some really positive feedback from caregivers around responsive caregiving, for instance, a lot of their impressions in these communities, but there were many risks to this. So attitudes, a lack of knowledge, like unhelpful beliefs, all sorts of things that were really getting in the way of providing responsive caregiving that these children needed, and many issues around substance abuse, obviously economic challenges, neglect, abuse, violence, and really that in many of these households, they were just failing to meet just the basic needs of children. And similarly to what we'd identified before, that really there were just insufficient services to help. So lots to be done. And that really helps kind of for us to understand what is the context into which we're doing this, and highlights really the important need for this kind of work to help address where we can the risks that these children are facing. And I just wanted to highlight a few of the quotes, and obviously there isn't time to read it all, but I mean, some of the feedback was really sobering, but also really affirming for the importance of this work. So many of the home visitors that we worked with, they said, well, they didn't, their parents didn't tell them they loved them. They didn't talk about feelings. So there's generational things that we have to deal with to understand, why and how these children are facing these challenges they are now. So I'm happy to share the slides, and you can read the quotes with a little bit more time. But what this also, a way of really helping us to understand this. And this came up in our work with young women in the Bukhali trial as well, is that it helps to think through this trauma-informed lens. And, a lot of work, we were chatting earlier about intergenerational trauma, comes from work in Canada around Indigenous populations. And so some of the work helps us to understand how do these things get passed on, and obviously then what can we do about it. And so one of the helpful resources that we found was around the social cultural model of trauma transmission, and that these social norms around how children are treated and how people interact, are passed down. Children imitate, they observe, and they learn about themselves. But I think what was really helpful in this particular paper that was highlighted is that this intergenerational transmission of trauma is not an intentional harmful act, that parents are not deliberately depriving their children of the nurturing care that they need, and that they maybe just don't know any other way. And what this Isabel et al. Highlighted is that there can be also a transmission of strengths. And so even though trauma can be transmitted, how can we understand these communities better? How can we understand the lived experiences of children and of caregivers, so we can see things also through a lens, a strengths-based approach, not rose-tinted glasses, but really understanding what are the things that are building strength in these communities, and how can we tap into those so that those can also be transmitted. And the change is possible. It's not easy, but it is possible. And obviously starting as early as possible and involving the caregivers in trying to break these cycles of trauma transmission is absolutely critical. And one of the participants specifically highlighted that. And we have a history of apartheid, of colonialism in South Africa that has really left such a legacy of inequity. And these caregivers and grandparents, really live with the scars of those inequities and pass those on. And through their experiences, really often don't see any other way. And so we can play that role of helping them see things through a different perspective. So I haven't got time to go too much into the tool, but this is just a few snapshots of what it looks like. And we provide feedback using a traffic light system. So green, everything's good. Orange, some things to keep an eye on. Red, you need some help. And then we developed the resources. So we said, would you like pamphlets? Would you like infographics? Would you like videos? Would you like voice notes? They're like, yes. So we did all of them. And again, all of the languages. And we decided to focus on some more general themes rather than here's a flyer on ADHD or here's a flyer on autism, which could increase the stigmatization. So the 5 themes are self-awareness, social skills, emotions, difficult behavior, and healthy habits and routines. So we have infographics that kind of highlight a key message for each of those. And we found a way to keep using our 24-hour movement guidelines. And translated these into, this time, just 9 languages. As I said, we've literally just come off the back of driving around and speaking to home visitors, speaking to caregivers to get their feedback on this. It's generally been received positively. Obviously, caregivers and children, there's different responses, but generally a positive overall experience. And in our settings, quite a few technology limitations, particularly in rural areas, that we need to be able to overcome, provide a lot of support during implementation. But what really came out strongly is these questions, much more than the resources, seem to be this trigger for some kind of mind shift that parents, we never thought about this. No one had ever asked us this before. We didn't know that our child didn't have any friends, or that they weren't, they didn't have social skills. I was telling them earlier, it turns out none of these children know they live in South Africa. Some of them think they live in America. But it really seems to have been quite impactful for them just to think about these things. And then obviously in the context of their relationship with the home visitor who's administered this, because it's not a once-off thing, it's part of their ongoing relationship. They can walk a journey with them to kind of become more aware of these things. And certainly talking about changes they've seen in their children, even in the space of just a few months. And the resources, after telling us, no, we don't want any printed resources, they loved the printed resources, and yeah, gave us a number of examples of how they're using those in other activities. So a parenting workshop on different forms of discipline can use our resources to help support those messages. So that's all from me. Obviously, all of this happens with lots of amazing students and early career researchers and collaborators, and lots of funding from all sorts of different sources. So thank you very much. And yeah.
Thank you, Cathi. That was fabulous. I was kind of hoping it'd go on forever. I know that maybe we can start from the audience and then see whether there are any questions.
I think there's one there.
There's one?
There's just a comment.
Okay.
So Ellen Lipnitz said, many thanks for an excellent talk. This is an important and impressive body of work.
Yes.
Okay.
Hi, thanks. Super interesting, and I love the technology piece. Question about WhatsApp. Like, did you have to go through approvals of like data privacy or storage of that stuff for using a chatbot through WhatsApp?
So,
do we have to, Catherine, do we have to
yes.
repeat the question?
Yes. So the question was around data approvals and storage for using WhatsApp as a platform. So we went the kind of quite conservative route in terms of this. We have quite strict Protection of Personal Information Act, which is very, very similar to GDPR. So certainly in South Africa, we have, things we need to follow. The tool is all being developed at UC Irvine, and the database and the back end is all there, all anonymized. So what we actually set up is that each home visitor, their number, cell phone number that they use is linked to only the children in their group that are assigned, and then a unique code, like a unique study code. We only have that information about how that's linked to the child's details. So that was to kind of take a very much more conservative approach in protecting that information, which has worked okay. It's not necessarily sustainable for kind of wider implementation. So we also now in the process of figuring out how do we still protect that data, but not make it overly cumbersome for people to actually use it. And in our settings, people change numbers quite a lot. Their phones get stolen or lost. So it is a little bit of a schlep trying to keep track of that. It wasn't quite as hard as we thought it would be, but certainly if we want to kind of go to a bigger scale, but obviously the data privacy and protection is a very important consideration.
Just thinking of such a great talk, and just thinking about the amount of research and insight that's gone into developing the resources, I wondered if there's opportunities to kind of share that. Like I see how universal the strategies are and really benefit so many families. And I remember hearing about the 24-hour guidelines a couple of years back. So similar, just ways to be able to disseminate and things like that.
Yeah, so the question was around dissemination and sharing of the resources. So all of these they don't belong to anyone. So I'm very happy, for anyone to contact me and to share. I mean, the Canadian Guidelines is an amazing website with, all sorts of tools online. And they've, their kind of visuals are really kind of powerful way of kind of communicating those messages. But we've opted for a very open kind of sharing policy. Obviously, things like websites, cost money to maintain. So we haven't always had the funding to do that. So that would be optimal to have kind of one central repository. But certainly with the resources from our Maziam Tanako project, what we've done is then connect with these different organizations who already do have other databases of ECD resources. So we've tried to add to what's already out there. So you're not necessarily creating another place for people to go to, but where there's kind of a bit of a one-stop shop or a well-known organization with resources that we've centered all there. And the funders are also very happy for this to be shared far and wide. So and we're in the phase of looking at, could these be used in other countries? And happy to talk further about that. And we'd love to see them use, and I'm sure the Jacobs Foundation would be delighted as well. Obviously, the name doesn't resonate everywhere in the world, but yeah.
Thanks for a wonderful talk. I was wondering a little bit about if there's more than one caregiver or like a parent, and then do you collect data all on secondary caregivers, whether they're grandparents, whether they're dads or moms or that kind of thing?
Yeah, so the question was about whether we collect data on other caregivers. Not specifically more than one. Often what we do is in that household, whoever's kind of seen as the primary caregiver, we will collect, if it's about, caregiver education or kind of household, assets or things like that. So we do try and make sure that we're getting someone who is able to kind of answer the questions around that, and ideally the person that takes primary responsible for looking after the child. And that is a little bit messy in cases. So particularly if you have a young mother, the grandmother is not necessarily that old, and she may be taking a more of a parental role because the actual mother is quite young. So I guess that is something that we could look at more specifically. So kind of certainly if we're starting to look at things like mental health, where we haven't actually, we have to some extent, but I think that we could probably do, if we went more specifically into looking at mental health, then making sure that we capturing kind of the variable influences in the home as well. And what's also tricky, and we picked this up a lot with our Bukali trial, because Soweto is a very transient area, and often transient in the sense that women move around a lot. So they might stay with the parents, then they might move to the boyfriend, then they might move to another boyfriend, then they might move back to the parents. So there's a lot of movement. Also, when women have babies, often they send the child back to the rural area where their family is from for a few months or a few years. So the child moves around a lot. So it's quite hard to kind of pin down, and it certainly doesn't fit into the category of like typical nuclear family. And we've recently done some work, qualitative work with fathers as well. And that's another whole minefield, because many fathers are not living with their child and not living with the mother of the child, but they're still involved in the child's life to some extent. And so, there's a very strong kind of absent father narrative, but yeah, the qualitative work showed that there are shifts happening, and many men are trying to kind of not replicate the experiences that they had of fatherhood. So not all peachy, but certainly signs that things are moving in a positive direction in some way, but lots of opportunities to work at that.
Great. There's one question. Any questions or just comment?
No, nothing is in the chat.
I'm going to ask, I'm just going to follow up with the question of like, if we were chatting about maternal mental health, something like that, if you were to think about like an intervention for maternal mental health, so do you have a sense based on either your qualitative data or your experience, what do you think would be feasible and helpful?
Yeah, so the question was around ideas for how we could address maternal mental health. Based on our work across these projects, I would say emotional awareness is just a huge need, and that is what we've kind of focused around the Bukali, the maternal well-being components of the early childhood phase. And that was actually developed before we did this other Maziam Tanako project. And now to hear from the caregivers that we don't talk about our feelings, we don't know how to talk about our feelings, we don't ask our children about their feelings, we don't know how to ask our children about their feelings. So, I mean, there's not no hope, but I mean, really, if we're going to try and see an impact in the children, like we have to start with the caregivers in terms of how do they cope with their own emotions? What vocabulary do they have? I did borrow a lot from Brene Brown's work that mapped out her Atlas of the Heart book. And we've tried to incorporate some of that, because it's just, if you just, I'm sad or I'm mad or I'm happy or just angry, I mean, you mentioned overwhelm. when we were chatting earlier. So just to kind of provide some more granularity to that. And we found that, yeah, those descriptions of just different feelings and disappointment or, yeah, various things, just to give them more of a vocabulary around their own emotions, yeah, is a starting point. Yeah, because it's not necessarily just all the psychopathology that we want to deal with, but it's just the everyday, like we talked about, stress, anxiety, maybe just low-grade depression, but just giving them some tools to just maybe function better on a daily basis, just to deal with those emotions, and hope that that would then give them some bandwidth to deal with that in their children as well. Yeah.
It aligns as well with the cognitive behavior therapy model, I guess, as well, in a way, is that first is that psychoeducation about emotions and what they are, and thing too.
Yeah. And being able to have the room to say, I'm sad.
Yeah.
You know, not like I'm grateful to be alive, I'm just surviving, but to have the permission to feel some difficult emotions, and for that to be validated, and not kind of minimized, because a lot of environmental factors, I think, minimize those emotions, force you to minimize, and you just have to cope.
Yeah.
But yeah. And I think one of the, obviously couldn't get into all the details around the Bukhali intervention, but a lot of the qualitative work has really uncovered for these women who have these very kind of fragile trajectories and very unstable lives, that this community health worker that delivers the intervention really, we think, is going to probably come out to be the mechanism of effectiveness, is that person who makes somewhat regular contact provides just like a little bit of stability in a very unstable environment, and someone that is interested in them, that talks to them, that listens to them. So we did some longitudinal qualitative work with women in the trial over a period of a year, and just some of the stories of what they came out after 12 months is, I didn't have someone to talk to, and now I feel like I can open up and I feel more confident. And we picked up these things in the control group as well. So even they get a telephonic intervention around life skills and nothing to do with health, but just having someone that actually cares, it seems to be really, really powerful. So, and obviously it's then in those community health workers giving them the skills around emotional awareness and increasing their vocabulary around emotions, and for them to feel it's okay, for people to be experiencing these things, because they come from the same community and they've experienced many of the same things. So really does come, I wouldn't say it's a therapeutic relationship, but it's certainly maybe more along those lines than just providing, educational information, but the social support component is really critical.
Yeah, well, I think we could probably talk for quite a long time about it. I think it's very humbling to see how much work you've done, and also, how different, but also how similar certain things are. Thank you so much for making it here, coming all this way and sharing this with us. And hopefully you'll come again to tell us about the next steps sometime. Yeah. So thanks everyone online and in the room.
Yeah,
and
thanks for having me.
Yeah, okay.